Greetings and Happy New Year from the South Asia Center of the Atlantic Council. My name is Irfan Nuruddin. I'm the Senior Director of the South Asia Center and Professor in the School of Foreign Service at Georgetown University. We are very grateful this morning to have occasion to bring together an esteemed panel of experts, of diplomats, academics, to discuss non-resident senior fellow Dr. Edmond Fernandes's brand new issue brief, which deals with important questions about how the globe can work together to deal with inevitable outbreaks of disease and hopefully avert another pandemic. Dr. Edmond, who is based in India, is a global public health expert. He is an MD by profession, and in this report, he argues that like embassies already have defense attaches, commercial attaches, what the world needs now is a new model of a health attaché, where countries would deputize to their embassies and consulates around the world trained medical experts who could be the first line of communication between countries to ensure that information is shared to the better of global public health. Over the course of the next hour, our panel of experts will discuss and debate his recommendations, assessing their feasibility for local domestic politics in different countries, as well as how his recommendations add to the existing scaffolding that the global public health system has already developed. Not all ideas are brand new. They build on the shoulders of giants, and we want to make sure that whatever ideas come out of today's discussion are best suited to be actionable and implementable around the world. To engage this conversation, we have asked Dr. Amita Vyas, who's a non-resident senior fellow at the South Asia Center, and also a professor in the School of Public Health at George Washington University in Washington, D.C., to moderate a conversation among our experts. Without further ado, I'm going to hand this over to Dr. Amita Vyas, and we hope that you enjoyed this conversation and urge you to engage with us if any of the ideas discussed here today seem to be of particular utility to you. Amita, the floor is yours.
Thank you so much. It's truly a pleasure to be with all of you today and to moderate this wonderful webinar on Dr. Edmond Fernandes's issue brief on how health attachés are the missing link to global diplomacy, wherein he truly lays out the important links between public health and global diplomacy and the important role potentially that health attachés can play in bridging these two domains. Certainly, the last few years of the COVID-19 pandemic has really highlighted how pathogens are not restricted to geographic boundaries and the critical role that global leadership plays in slowing down and preventing future pandemics. As we live in such an interconnected world, it will be imperative that we ensure that public health is a priority and a key component of global efforts, both within and perhaps most especially outside of traditional health institutions. So today we are joined by an esteemed group of panelists with decades of experience and expertise in global health and diplomacy, and they will be sharing their insights and reactions to Dr. Fernandes's remarks. As noted earlier, Dr. Edmond Fernandes is a non-resident fellow of the Atlantic Council and the South Asia Center. Our panelists today are Ambassador Mustafa Jawara. He is Ambassador Extraordinary and Plenipotentiary to India with accreditation to Sri Lanka, the Maldives, and Bangladesh within the Ministry of Foreign Affairs for the country of Gambia. I'd also like to welcome Syed Muntasir Mamoon. He is the Chief Innovation Officer for the Director General in the Foreign Ministry of Bangladesh, and Dr. Rebecca Katz, Professor and Director for the Center for Global Health Science and Security at the George Washington University. To start us off, I'd like to ask Dr. Edmond Fernandes to provide brief remarks on his issue brief. Dr. Fernandes?
Thank you, Amita, and a pleasure indeed to interact with distinguished guests from within South Asia and around the world. At the outset, let me thank the Atlantic Council South Asia Center, Professor Irfan Nuruddin, the leadership, and also Harris, Misha, and the core team to have facilitated the outcome coming out in the form of a policy brief. Health attaches, global health diplomacy, global public health, and COVID. All of this have been conversations that have at some point tickled our mind, if not engaged on seriously. But one thing has been certain, which has been my motivator for putting health attaches at foreign ministries, is that we are at a space in time, probably a space like never before, where the health affecting one nation affects all nations around the world. And if this is not enough, today, as the conversations of climate action grow stronger, as the world sees unprecedented natural disasters in the form of flooding, cyclones, earthquakes, what does this all have? Not just for public health consequences for regional neighborhoods, but what does this also mean for diplomacy at large? What does this mean for trade, economics, sustainability, and human development in general? With this few lines, which motivated me to dwell deep into the policy brief of why foreign ministries should really push health attaches around the world, and probably also at zero cost, over to experts to understand where can we improve from here, what lessons can we learn from this. I am willing to learn, unlearn, and relearn. Thank you.
Thank you so much, Dr. Fernandes. I'd like to start our discussion today with Dr. Rebecca Katz. It would be really wonderful to hear from you around how do we take the remarks in the issue brief that Dr. Fernandes laid out and think about how we build on current efforts and where potentially some of the gaps are currently as we think about this bridge between, global public health and global diplomacy. Dr. Katz?
Thanks, Amita. And let me brief correction to your introduction. Amita and I had the pleasure of working together for about a decade at George Washington University, but I'm now at Georgetown University, about 2 miles down the road. All the Georges in Washington. So I really greatly appreciate the opportunity to be part of this conversation. We've been working on helping to try to define what global health diplomacy is as a field for over a decade, and there has, as Dr. Edmond mentioned, there's been tremendous interest lately in thinking about how we not only define the field and the professional opportunities, but also how we train to meet the needs of the future global health diplomacy workforce. We've also been working for years within a diplomatic context on thinking about academic training and institutionalizing health diplomacy within governments. I think it's a very exciting time, right? There's a lot of interest in the space. From everything from academic entities to ministries of foreign affairs around the world. In the United States, the Department of State intends to create a new Bureau of Global Health dedicated to improving and enhancing health diplomacy. And this includes through the embassy structure, which includes not only the existing health attaches, but also the science envoys and the foreign service officers who take on the role of thinking about health. I think on the role of health attaches, and hopefully we can have this discussion. There may be a bit of a nomenclature challenge here. They are essential, and they form a critical function. They also, they exist. There just aren't enough of them. So again, in the United States, there are currently health attaches in Brazil, China, India, Mexico, Kenya, South Africa, as well as in Geneva. And actually in Geneva, there's sometimes a deputy attaché as well. There are also people from other agencies outside of the MFA that have similar titles. Like I think at one point the Air Force had military health attachés. So building off of that military attaché program, but just specifically for health. I agree they need to be expanded. There is always more interest, both from the embassies themselves as well as from possible applicants, than there is ever funding for. And there is an ongoing debate about how one does that and even where these attachés sit. So again, in the United States, it's a little complicated. They report, they are part of the Department of State system, but they report through HHS and the Office of Global Affairs. And then there's also Foreign Service officers who have a health account, which is sometimes almost more appropriate in smaller embassies. And again, at the same time, we're seeing multiple nations point that they're creating the title of Global Health Ambassador, right? So Sweden, Norway, Finland, France, Japan, the United States all have titles of global health ambassadors. Australia has a regional health security ambassador. And this is in addition to the cadre of ambassadors in the US and around the world who have become, through experience, informal global health ambassadors. These are the professionals who have negotiated agreements, implemented programs like PEPFAR, coordinated response to these major public health emergencies, and really become leaders and advocates in the space. Which I think gets to both Mita and Dr. Edmond's point here that nations around the world, I think, are really acknowledging that global health and climate and other transnational threats are core parts of foreign policy and national security, which raises a challenge for how we organize our ministries of foreign affairs, which are often, as we all know, organized more around geographic challenges. Now, I do have a whole bunch of really specific questions, and I don't know if it's worth mentioning now or kind of coming back to, but I think I'm a little challenged. Again, I think it might be a nomenclature thing, but I think that what's described in the paper isn't necessarily the health attaché as we currently define and currently have them, again, at least in the US structure, but more around, this idea of core advisors, which I really love. And maybe even a core of host country professionals who can even be nominated by the host government that serve all of the health and science attachés in a given country. I think, a community that can amplify messages and bring together data for an entire community, or convene meetings. I think maybe even like a counter proposal to think about, like, for host governments to propose these advisory councils of people with technical expertise that can maybe be responsible for occasional briefings and act as soundboards and conveners to provide context for embassy personnel in countries. So again, let me stop there. But again, I have lots of really specific questions if we want to come back to, but again, really appreciate the opportunity to be part of the conversation.
Yeah, and absolutely. We'll get back to some of those questions. I think we're all very interested to hear some of the questions that you have. I would like to turn it over to Ambassador Jawara to hear about sort of your thoughts on this report, given your, current, both your experience as well as your current position working, within the ministry and working within, governments, and sort of the role that you see a health attaché playing.
Thank you. Thank you very much for this opportunity to be here with you. And I thank Dr. Edmond for inviting me to this panel discussion, and to Atlantic Council South Asia Center for also this opportunity to be here with you. This is a very, very important topic. Health attaches now the role and the functions as Dr. Edmond espoused here, this put across is very, very critical in the health delivery system in terms of diplomatic, missions in that area. Because, for example, the Gambia, currently we do not have any health, attachés, because what is very critical to our function. In India, India has become the number one, health, tourism destination for most patients in the Gambia. and not only Gambia but other parts of Africa. India has become a health tourism destination point. So the function of health attaché has become more crucial in this, if you look at it. But the mission, embassy, we have, for example, currently we have about 5 diplomats, and the role of the health attaché has now been divided among these people. I have to kind of assign some of these responsibilities to councillors and force secretaries and even council ministers to take charge of that. So if we have a health attaché, that will kind of assist us in a great deal. But there are so many questions that need to be asked and answered if we are to embark on that route. Dr. Edmond raised so many important points that at some point probably will have to engage him to kind of elaborate on those. But this is a opportunity to kind of dilate on this very, very pertinent issue, especially after COVID, post-COVID 19. Thank you.
Thank you so much. Dr. Mamoon, I'd like to ask you next, as you were reading the issue brief, were there any specific questions that you had that sort of arose for Dr. Fernandes as you were reading through the report?
Thank you very much. And I must, before I answer that question, I must thank you and the Atlantic Council for hosting such an interesting and timely event at this moment. Because a couple of years before, even just a year or two before, health used to be a country's constitutional or public rights issue, public goods issue even, for that matter. It was public good health. But particularly because of COVID-19, and I believe that COVID-19 might have been the first amongst many, it's certainly not the last. So it has become an issue of both regional, trans-regional, and probably a global interest. So I must thank you, the Atlantic Council, and Dr. Edmond for bringing out this very timely issue brief. Yes, there has been a lot of questions, and some of the questions might be very similar to what the Georgetown professor has just mentioned, that whether the attachés could have been more appropriately defined as advisors, because attachés are carrying out day-to-day tasks most of the times, more tactical tasks, but advisors would be more on a strategic role. Yes, from the Minister of Foreign Affairs in Bangladesh, we set up the COVID cell when the COVID-19 outbreak had begun. If you look at it, you will see that for a country of more than 160 million people, we did a good job of containing the mortality and also the spread of the disease, in spite of us being a very, not only very populated, overpopulated and very intense habitation. So we have done it well, and thanks to some of the leadership components that we had from across the different ministries, not only the Minister of Foreign Affairs, Minister of Health. And that is something which almost forced us as a group to think, or let's say rethink and relearn the ways that we do business. Diplomacy is changing, evolving, or the tools of diplomacy is changing, because diplomacy has been probably there since the very beginning. Some say that it is the oldest profession on this planet, diplomacy for human beings, not the other one, diplomacy. So that is something which is evolving, and so is statecraft, the way that states constitute themselves. Post-Westphalian states is a recent phenomenon in the many millennia of human history. The way that we see states in our part of the world, particularly in the Indian subcontinent, is more about governance. And it's slightly bigger in terms of our manifestation as a system, as an institutional narrative. So the epistemology of diplomacy, that has changed, and that is evolving very fast. In terms of health and education, or for that matter, skills, particularly when we are approaching the 4th Industrial Revolution and some say the 5th, And with outbreaks of pandemics like COVID-19 and SARS and MERS, MERS is also a very important issue for us, particularly those who are engaged in the South. The whole narrative of South-South cooperation, maybe South-South-North cooperation, that needs a rethink. So when I was looking at the issue brief, these are the many layers, the fields, the players, levels, and layers. These are the 4 things that I was just looking at. So yes, there are many questions, but first, maybe as Rebecca was thinking, that maybe it's a question of nomenclature as well. Would it be a health advisor or a health attaché? Because the tools of diplomacy, the intended objectives of diplomacy, promote, project, protect, these things are also evolving. Ethnicities mean little. Day by day, it's becoming smaller, but ethnography is becoming higher. Your allegiance, where your mind is, that's where your home is. So in terms of the way that the whole world is configured, the whole structure of governance is configured, that itself is changing. And that does not yet have a very specific task profile. Instead, it's evolving and it's like a flux. It's evolving very fast. It's almost like a flux vortex. In that kind of a situation, I believe that the first question would be, is it an attaché or an advisor? Because the advisor would be advising and it would be a bridge. It would not be a one-way traffic, it would be a bridge between and amongst nations, governments, and also people. And the people would be a very important component here. So I believe that, yes, there is a whole lot of questions and commentaries that we could all make. And yes, I'm here to listen first and discuss later.
Thank you. Dr. Fernandes, given that multiple panelists have now sort of thrown out this question around how should we really consider whether or not, what you have laid out is truly a health advisor or a health attaché, and some of the issues particularly related to governance around those. Would you like to respond to that?
Yeah, definitely. I think there are 2 ways of looking at this, but nevertheless, they become 2 sides of the same coin. As for example, the United States, which falls in the high income country bracket, calls them health attachés, but they work in a slightly different road. But at the same time, if you look at the British High Commission, they say public health advisors. Now, the question here is not about whether it's merely a nomenclature role. The point, what I'm trying to raise is traditional diplomacy no longer works. And it's in the best interests of foreign ministries to acknowledge this fact. I mean, if it's a high income country wanting to invest in health attachés, make some robust kind of developmental narratives like how USA does or DFID does for the UK, fair enough, you can appoint somebody on a daily basis who manages the office and supports the consular work. But if it's a low and middle income country, which is resource constrained, which probably has conflicting priorities in terms of investments, then I don't think health attachés on a daily basis can play a role. So thereby trying to say that if you look at my policy brief, I did mention that health attachés, assuming roles like honorary consuls. I mean, take for example, if I have to be part of any foreign mission, I would have to dedicate sizable amount of time to support the mission. There's no point putting out a paper and saying that, hey, this is what I think is going on. There would have to be certain consular privileges. There would essentially have to be certain kind of recognition coming in from the foreign ministries. And that's when somebody feels motivated if there is no incentives in terms of monetary support. So, I mean, you can call it health attaché, you can call it advisors, that's left to the prerogative and wisdom of foreign ministers. But like Ralph Waldo Emerson said, that if one life has breathed easier, we have met with exceptional success. In similar terms, if one country can breathe easier because this policy brief tickled thinking in diplomatic segments, I would have met with exceptional success is what I would say.
Dr. Mamoon, would you like to respond to that?
Yes, I suppose I would. There is something called the inquiry demand. See, I work with the University of Oxford at the Side Business School, and we work on a platform with a framework called the TMO framework, Technology, Markets, and Organizations. So ultimately, the epistemology of thoughts, the economic thoughts, the way that we organize ourselves. Some say that we are Keynesians, some say that we are monetarists, and some say that we are pragmatists or realists or Adam Smith type of things. But essentially, I personally believe in, I'm digressing a little bit. I personally believe in more of the Austrian school of economics. When you have time limitations, when you have many options at hand, but your certain preferences are there, what do you do with it? So as Dr. Edmond was mentioning, that certain countries may be be in a better position to deploy health attachés or health advisors, whichever way that you call it, although the nomenclature would definitely have certain connotational differences, and not only connotation, but also role differences as well. But yes, there is a reason that these two names are different. And some say that what's in a name, but a lot of things are there in a name, and names often mean many things. Essentially, what happens is that the health attachés or even health advisors, whichever way that you like to call it, must cultivate, must incubate trust. See, what is missing when we had the beginning of the COVID-19, just look at it, take a look at a couple of months before when COVID-19 was just spreading out. I believe that to some extent, there was a tendency amongst many of us, I'm not going to blame any country in particular, but many of us, let's put it that way, because after all, it's one human race. So any death anywhere is everyone's business. And we have condolences for those. But there was a tendency for many of us to deny certain things, that this didn't happen. But they didn't help anyone. So that element of trust, that went missing for a couple of weeks at the very least. And it took a huge lot of efforts to bring that trust back. When that trust was also in connivance with confidence and the market mechanism started flailing if at the least. But that started with the loss of trust, and that moved into solid market preferences and conditions and conditionalities. So essentially what is happening is that there is a demand which we can feel, we cannot probably articulate. We call it the inquiry demand. So there is a void, an institutional void, in the way that foreign ministries or diplomatic agents, for that matter, operate. And they know that there is certain bit which is missing. As Dr. Edmond has said, the missing link. This could be a void, and the missing link is just a link in the chain, but a void is a void in the way that you think or you articulate your thoughts. Now, all the things that we say and all the things that we do and all the things that we actually think we have said are three different sets of, or at the least three different sets of activities. There is a Cassandra's curse involved in it. So essentially, this void of institutions, institutional narratives of maybe the epistemology of public health itself. I keep repeating these words, epistemology, institutions. These are important elements. This is how you see that why we should be doing certain things as we would be doing. And that void, that inquiry demand, that we know something is missing, but we don't know exactly what it is, that void can be filled up with the wise deployment of agents and elements such as those mentioned in Dr. Edmond's paper. But definitely, as Ambassador Jahara would be probably in a better position than I am from Delhi, because I was in Delhi a couple of years before. But I believe that there are certain things which would probably need a little bit of tinkering because of the way that diplomatic services are organized. So the roles of honorary consuls have very specific sets of responsibilities, and also the host government privileges. Even if, for example, even if I would like to nominate someone as an honorary consul or as a health advisor for our mission in India or anywhere else, we might need some reciprocal arrangement from the host government. So there is a lot of discussions needed in that respect. But yes, in terms of trust, I believe that that's the beginning. These health attachés or advisors, the way that you put it, the first job is to inculcate incubate, nurture an element of trust in the systems that we operate with.
Thank you, Dr. Mamoon. I'd like to continue on sort of in this thread and in this conversation, because certainly whether or not it's a health advisor or a health attaché, the effectiveness and the impact of a person in this role is really dependent on resources, capacity, authority that the person would hold. So I would like to ask Rebecca Katz. Rebecca, what are your thoughts on this? I know you brought this up earlier in the conversation as well, and then also to open it up to you for any other questions you have for Dr. Fernandes.
Oh, thank you. I mean, I do have to say I continue to be a little confused, and maybe that's because I'm just thinking about the way that the diplomatic corps currently functions. And so in my head, acknowledging that we are in a different world, and ministries of foreign affairs are really rethinking how to address these transnational threats, how to build trust, how to actually operate more effectively. All those things are happening, but still we have a system that operates in this embassy structure, where the type of role that you're describing, again, as currently defined, basically, I may misunderstand it, but basically identifies people from a host government who would then be asked to be taking on diplomatic functions of a foreign service officer, or even to negotiate on that as part of with a foreign government. And that I can't get beyond that. I'm really quite stuck, because I operate in thinking about, we think about our diplomatic corps and attachés as they currently exist as part of that. They fall under the purview of the ambassador. They are you talk about this idea of living amongst locals and the importance of that, but that's not, that I think isn't necessarily consistent with operating as part of a system and an organ, and even thinking about how that works within the system. So I keep going back to this idea of having, having advisors, having councils, having people who can be called upon. I think, many of us who live in Washington have a lot of coffee with a lot of people from different embassies. Doing that in a more organized way sounds fantastic, right? In a way that you actually have a system, and you in some ways could represent your host government as experts and outreach into different scientific or technical communities. But I stick to the point that the job of the diplomatic corps is you are at the core representing the interests of your own country and your own government, and then working with the host government. Hopefully, we're all moving to advance health together. But I struggle a bit with what you are proposing, and the kind of roles and responsibilities and authorities you would be giving somebody because of a technical expertise, but not necessarily as part of the system of foreign policy. Which honestly then goes back to the comment about training. I actually very strongly believe that this is an actual field, and we're trying to where technical training is actually, and when I say technical training, I think technical training in health diplomacy is critical. And that that I struggle with the language in the report about how just having a medical degree therefore once qualifies somebody to do a thing, where I don't think that's actually, I don't actually see it that way. So I just wanted to put that out there. Thanks.
Dr. Jawara, would you like to respond to the last few, speakers around, within the system, what seems to make sense, given that you are currently in an embassy?
Although Dr. Edmond's point, the proposal is a very good one, but one must also consider that a health attaché, the functions would be kind of different from an honorary consul, because the attaché would have allegiance to to his or her, send him or her to, to the host country. And honorary would be, would have allegiance to the, to their country. That's the, I could see that, health attachés would be appointed by their, the country.
Dr. Jawara, I think we're having some connection issues with you, with your audio. It appears that you have frozen on screen. So I'm just gonna maybe take a pause while we work through that to get you back, and give an opportunity to Dr. Fernandes to please respond to what some of our panelists have been talking about around sort of issues around within the system, what would be the most effective way to implement a position like this.
Okay.
No, so
Can you hear me? Yeah.
I think
Hello?
Ambassador is back, so.
You hear me? Yeah.
Yes, go ahead.
Okay. Yeah. Yes. I think we health attaches are critical to this. But the how do we go about it is the is it Dr. Edmond mentioned that.
No, so
Dr.
maybe
Jawara, I think
Amir,
Ambassador Jawara, we're still having some issues with your audio and your video. So I think let's work through that with our Atlantic Council team. And Dr. Fernandes, I'm gonna throw it over to you to please respond.
no, so I did hear Ambassador Jawara, and I like the point of allegiance. So it comes back to resources again. So if a country or if a high income country has the bandwidth and budget and the seriousness to take forward a health attaché in a full-time appointment in the embassy or the high commission, please do it. Likewise, what I'm trying to propose, which Rebecca was not clear of, is that if probably that it's a low or middle income country, which does not want to invest on a full-time health official, it is wiser to probably have a local from the host country serving as an honorary health attaché. Now, if this does not fit into the frameworks of the Vienna Convention, or it does not fit into nomenclatures, fair enough. I mean, I am not a career diplomat. I stand guilty as charged. So it's an opportunity to work around fitting into nomenclatures. But if, say, for example, the low or middle income countries do not have the resources, identify local global health leaders who could fill in this void, probably interact and interface with embassies to take forward the bandwidth of health. What is diplomacy end of the day? I mean, cutting across all the high-end theories that diplomacy has to offer, diplomacy, in simpler words, for a person who's not a diplomat like me, would probably, or probably for an ordinary civilian, is nothing but negotiations, is interpretation of country preferences, is conversations at large. So what are we looking at? We're looking at probably two different countries, host country and the sending country, engaging to come together for a conversation on global health, for a conversation on national and regional security, for a conversation on shared health intel. I mean, this is not rocket science. This is simply political will that needs to be executed. And I mean, if you don't want to do it, you can bring it under any convention, you can bring it under any negotiations. Look at how the Paris Agreement on climate change is going. Where are the commitments? I mean, it can always be a beautiful convention held on this. But if foreign ministries are serious, which most of them are, then it's about identifying how do we want to fit into the health security bandwidth You call it health attaché, you call it public health advisors, which Rebecca was more comfortable of, or you call it anything you want. But my proposition is let's do it. And I think that's a fair ask in a time when we are bombarded not just by refugee crisis, by migration, by trade issues, or by natural disasters or climate change. It's a planet in peril. And if we don't take issues seriously now, what kind of a legacy are we creating for future generations? What kind of a diplomacy or regional security are we trying to build? Is this all about political narratives, or is it about a greater goodwill, which we collectively look at as a one world, one health, one planet?
Thank you, Dr. Fernandez. Ambassador Jawara, I think you're back, and I know you weren't able to finish some of your comments earlier, so I'd like to give you that opportunity now.
I think we all agree that, the point that Dr. Edmond raised is very important. And this, position is necessary in all, in all diplomatic missions. But, the problem that arises is that the cost aspect, of the, for example, a country like the Gambia, we are struggling with our current, kind of setup. You have the, ambassador, you have the deputy ambassador, counselor, and so you adding a health attaché to that also involves a lot of cost, because running a position in the diplomatic mission is very expensive. So, it's about cost, and also some policy issues. For example, in the Gambia, whether the health attaché would be appointed, through the foreign ministry or through the Ministry of Health. That also is a question that would that will come into play, and at some point there might be even kind of push and pull that the Ministry of Foreign Affairs will want to take control of this. This position should health would argue that. So just like the military attachés are right now, and we also have in some missions tourists, Ministry of Tourism, we have tourist attachés that will take care of kind of promoting tourism in the foreign country. So these are very, very important positions, but it becomes critical when you look at the cost. And for example, if the host country wants to assist in some of these things, I think that is fine. But how do you go about it? Appointing honorary country, that's no problem. And in fact, to be a health advisor, that the health, the host country would also have to, have a say as to, who is qualified, to be, in this position. You have the diplomatic mission, and in the host country, kind of, deciding who is qualified and who is not qualified. But we all agree that it's a very, very important, position, and post-COVID, we all need it. But can we afford it? How do we go about it? I think that is the challenge now we are facing.
Thank you, Ambassador Jawara. I'd like to give Dr. Mamoon and Dr. Katz an opportunity for final insights, remarks, and questions, and then to end with Dr. Fernandez, your response to those. So we can start with Dr. Mamoon.
Thank you. I believe that what Rebecca had said, and if I may clarify a little bit on what she had said, it's about allegiance, because Minister of Foreign Affairs or the diplomatic corps is essentially concentric to a national allegiance to a sovereign state agent, to the state's level sovereignty. Now, that's where the mechanics of how the health attaché system would work. I think that's where Rebecca got a little bit, as she had said, confused. And so was I. And so am I still, because I believe that when you appoint someone diplomatic corps or inside a diplomatic corps and give him a diplomatic passport, the first thing that happens is whose man or woman he is or she is. So is it the host governments or the recipient governments or the home government? So that's something like people never change no matter what happens. Usually, although we aspire to be bigger, greater, stronger, but in the core of our hearts, we still remain somewhat insecure. And sometimes even state systems remain so. And that's where the anomalies, the asymmetries come in. So what Dr. Edmond had said or what is written in his policy brief, in his issue brief, if I have understood correctly, he has very great craftsmanship. He has articulated a vision of a world where you have regular systems of conversation, of dialogues. Yes, that's what we aspire to be. But that is, I would not call it a utopian situation, but that's a desired state, maybe a desired end state. But that desired end state requires a lot of working in between. A whole lot of work needs to go in before that. So they're just thinking, if you could think of, since Ambassador Jawara had also mentioned about the cost, if you could create a pool of professionals, public health professionals or otherwise, who have some sort of a diplomatic nature, who could probably be working through the WHO or maybe other organs of the UN, or even regional and sub-regional organizations like the African Union, the European Union, or maybe the SARC system, or let's say the BIMSTEC and other regional organizations that we have in South Asia and Southeast Asia and other places. If you could have a pool of professionals which could render its regular diplomatic services, pseudo diplomatic services, not maybe a direct diplomatic service, but a conversation starter service like that, or maybe a transfer of technology service, because of the vaccine thing which happened 2 years before, it was an eye opener that suddenly certain things could have become life-saving. And in spite of all the efforts, it was purely the goodwill of nation states and governments and the people of different countries, which ultimately led to the prevention of a global disaster. It is a disaster, COVID-19, so many deaths, but still then the deaths could have been much more. Since governments came together in spirit of goodwill and decided to work together, I think that's when we came out of our very much egoistic, I, me, and myself. That's all that it matters. From that egocentric approach towards life, conventions, the governance and diplomacy, to the spirit of goodwill and let everyone live and let live. That is it's a huge leap which you are thinking of, if I'm not wrong, Dr. Edmond. That is something that we aspire to be, but it would require a heavy deal of work, serious load of work would be needed to have it done. So yeah, that's where I am at this moment.
Thank you, Dr. Mamoon. Rebecca, Dr. Katz, let's hear your final insights.
It's hard to follow Dr. Mamoon. I thought that was I thought it was an excellent summary and an interesting proposal. I think the only thing I would add here is just to reiterate that it is a really it is an interesting time. There is a lot of swirl. There is a lot of movement happening in the health diplomacy space. We are in the midst of multiple negotiations on international agreements, some of which talk to each other, some of which don't. There is a lot of programmatic efforts that are happening between donor countries and recipient countries. There is hopefully a rethinking of what that relationship looks like. There's a lot of movement that's happening amongst regional organizations as well, and kind of some rethinking about who nations trust in this global system. And these are really, really important events that are happening, as well as this moment to think about kind of the relationship building that happens around health and the critical role of transnational threats of health and climate. So again, tremendous amount of swirl. I think to everybody's point, there's just not enough people who have the training and the expertise and the experience to be involved in moving some of these conversations forward. So thinking about to Dr. Mahmood's point, there are a tremendous number of groups in civil society who I'm sure would love to fill the role of kind of being the world's kind of experts and advisors. And I think that you know, thinking about how to best utilize the experts who are out there, the people who care deeply, who want to help move these agenda items forward and improve global health, health equity, what actually is health equity, all of these pieces. I think there's real opportunity to come up with some creative solutions, but I just go back to thinking about how we do that while also respecting state sovereignty, while also respecting the role of foreign policy and national security and the way that nations currently approach that. So I'll end there. Thanks.
Thank you, Dr. Katz. Dr. Fernandes, any final comments or insights before we close our session today?
Yeah, I think if this paper has left people thinking, then my purpose is achieved. Particularly because I'm not a diplomat. I'm a public health trained physician who spends my time in clinics and then supporting developmental work around communities. But in all of this process, diplomacy, global health has somehow come natural to me. And I think that's one reason why Irfan brought me into the Atlantic Council in the first place. Otherwise, I don't know what should a physician be doing in an Atlantic Council setting. But all said and done, what I want to leave a final message to stalwarts out here on our panel is, if in the 1950s, John F. Kennedy could think of an idea of reaching the moon, health attaches or public health advisors is not very difficult. In this process, I would be very happy to work with any of you with my limited knowledge of interpreting global health diplomacy in shaping the kind of egalitarian world we aspire to achieve, and also in strengthening regional cooperation, which essentially fits into diplomatic mandates, whether formally, informally, or through human altruism. I'll leave it at that. But at the same time, once again, I would like to thank Ambassador Jawara, Dr. Mamoon, Dr. Katz, Irfan, Amita for moderating this, and Harrison Misha. I mean, to invest 1 hour of your intellectual time for a purpose larger than all of us is a very soul-satisfying experience. Thank you.
Thank you, Dr. Fernandes. You know, this conversation today has been incredibly interesting, and I think where we all absolutely agree is that we need to move beyond whether or not we need positions around advisors or health attaches, but to really think about how can we ensure that whatever that position is most effective, that people serving in those positions are well suited, well trained, and fit within our current government and diplomatic structures. And how do we ensure that they have the authority and resources so that they can truly be effective? So I'd like to thank all of our panelists today. A special thank you to Dr. Edmond Fernandes for his issue brief. Thank you to the Atlantic Council and to the entire team at the Atlantic Council South Asia Center. And I wish all of you a happy new year.